Hello, everyone. My name is Dr. Jane McKay, and I'm here to present an approach to long COVID, post-COVID condition assessment and management. This has three objectives, if you remember correctly. Uh, it's not. So explaining the diagnostic criteria for long COVID, identifying and applying evidence-based tools and strategies for managing long COVID in practice, and discussing the challenges experienced by people with lived experience, including interaction with the healthcare system. So I have no conflicts. And I'd like to start by just this quote, because I find it's very appropriate. Medicine is a science of uncertainty and the art of probability. Very true in the world of long COVID. Long COVID, persons with lived experience, you'll hear more in a bit, but in May 2020, many were experiencing longer-term symptoms. There was an incredible lack of recognition by healthcare professionals, and the term long hauler and then long COVID sufferers self-organized to lead and advocate for their needs to be met. And it's been an incredible effort worldwide. And most everyone that I see prefers the name long COVID. So one of the difficulties with this condition is the confusion over the definitions. Over the last 5 years, there's been multiple different definitions, and I've listed a few on the slide here that comes from an article in Lancet. It's a good review article. And just please note that none of them require a positive COVID test. So what is the definition? This is the WHO definition. Post-COVID condition, commonly known as long COVID, can affect anyone exposed to SARS-CoV-2 regardless of age or severity of symptoms. It's defined as the continuation or development of new symptoms 3 months after the initial SARS-CoV-2 infection, with these symptoms lasting at least 2 months with no other explanation. So I'd like to just give you a snapshot of Canada. It's 3.5 million Canadians from the 2023 Stats Can report. It affects daily activities of living in over 50% of individuals. There's an inability to work, and multiple studies are out there, but it can be in some populations as up to a half. But different populations have different data. So just a little bit about the epidemiology. So it's very difficult to give a true estimate of long COVID because of different cohorts. And I've given 3 or 4 examples of some longitudinal cohorts that are mainly community-based that give quite a lot of data. One is the REACT, one is the post-hospital COVID. There's some mixed community and hospital studies in Recover Initiative USA, and then the UK Office of National Statistics. So I always encourage everyone to watch the React Long COVID study that is on the Long COVID Web webinar. Very, very helpful. And the last estimate that I found was approximately 10% of people with SARS-CoV-2 infection will develop long COVID. And that's it changes. So it's hard to keep on top of that number. So some of the principles I like to talk about in assessment of long COVID in your office space is always mask. That's the first thing that I think is important. And when you are taking a history, it's vital for treatment planning, as in all cases of medicine. So you would like to know how many COVID infections they have had, because the number of infections can increase the risk of long COVID, vaccination history, and the symptom burden and health impact, over 200 symptoms. Because I prepared this talk for an internal medicine trainee group, I just wanted to highlight that we cannot forget the neuropsychiatric complications that are important to clarify. And if you don't have the information to gather that data, there's survey tools that can help you. And really always clarify the impact of all the symptoms, not only on the individual, but on their family and on their work, obviously. Symptom surveys do exist, and they may be helpful if you're unfamiliar with this area. And this is a very interesting one that I found recently that has about 45 different symptoms, so a little bit more honed in, so to speak. So what are my guiding principles? A multidisciplinary or interdisciplinary team is essential. Shared decision making with your patient is a priority. There is no therapy for long COVID. Many trials ongoing, but that doesn't mean there isn't symptoms that you can treat. So symptom management of medical symptoms and psychiatric symptoms, incredibly important. And really always be open and curious with your patient, because they will bring you information and they'll bring you studies you may not heard of. And just, I think this is where we need to accept we don't know everything, and you have to maybe come back at a different date with the information. So the uncertainty that many individuals have in medicine can be really difficult and uncomfortable, but it's just really important to understand that humility can guide us. So because this is designed for trainees, I've started with a case. So this is a case from my practice who's agreed. This was a 47-year-old woman who had 3 episodes of COVID. Her past medical history was migraines, the severe debilitating headaches after her COVID infection, COVID, as I've mentioned, gluten intolerance, and a diagnosis of post-COVID ME/CFS. She used to work for Service Canada. She's currently on long-term disability, doesn't smoke nor drink. Again, I'd like you to pay attention to what maybe the over-the-counter medications that the individual may be taking, because they can give you insight into what the individual may be doing in their own research and information gathering. So when I have a look and see famotidine, loratadine, Benadryl, I may think of asking about mast cell activation syndrome symptoms. Also, supplements are key as well. So in this case, because it was very early on in the pandemic, every test was done. So they were there, and the tests, as you can all see, there's lots of N's, meaning normal. So when you go to look at what investigations you should be ordering, the PCC guidelines for investigation are really a good resource, and often what I say for everyone as an individual to use. And so in this woman's situation, given she came to me a bit later, really the workup was quite limited. BNP was added because of some shortness of breath. But please go to the PCC guidelines to look up investigation. Essentially, it's limited and then symptom-based. So in July, she had multiple symptoms: shortness of breath with 1 flight of stairs, significant headaches, paresthesias in her feet, fatigue and PEM lasting 1 to 3 days, precipitated by both cognitive, emotional, and environmental triggers, very limited in terms of activity, sleep impairment, and when she had reviewed the ME/CFS diagnosis, which is a diagnostic questionnaire, she still met that. Again, apologize. I also have sleep impairment twice. So important to note, she was dizzy with upright posture, and the nasoline was used at that time because of evidence that ME/CFS, where they often use this, was present. So that's why. And she couldn't complete the 10-minute stand test or the nasoline because of dizziness that was occurring with the tachycardia. So fulfilling the concept of orthostasis with standing. She was essentially housebound and recumbent most of the day due to her symptom burden. So when her first assessment was done, it was virtual. And then my impression, I kept it very short, but it could have been longer. But what I had felt that she had is long COVID-associated ME/CFS, and she was in the severe category of this, 25%, migraines that were worse with COVID, and POTS that was actually confirmed in the office. So when you're trying to make improve symptom management, you have to start looking for the validation of the symptoms that you're seeing. So this is some of the results that you see of the standing tachycardia, more than 2 beats, and no orthostasis in the blood pressure, but certainly had significant lightheadedness. And again, this is specifically came out of the ME/CFS literature. So what is the diagnosis of POTS? This comes from Dr. Satish Raj, who wrote this in the CMHA. Sustained heart rate of greater than 30 beats per minute for an adult, within 10 minutes of upright posture, absence of significant orthostasis or orthostatic hypotension, frequent symptoms of orthostatic intolerance that are worse while upright with rapid improvement upon returning to supine position. The symptoms can vary. They can be lightheadedness, palpitations, tremulousness, generalized weakness, blurred vision, fatigue. The symptoms need to be there for 3 months, and there needs to be no other competing diagnoses. So again, multidisciplinary team or interdisciplinary team is incredibly important in management of individuals with long COVID. So I'm just going to focus on the symptoms that this particular individual had, just to give you some examples. So headaches. So long COVID headaches are associated with 3 types of headaches: tension type headaches, migraines, and newly daily persistent headaches. So proposed mechanism of the headaches, I do like to go over mechanisms with my patients. Trigeminal vascular system activation, immune system activation in the central nervous system, predisposing headache biology and history, and many gray-white connective differences that can occur. So this is a very useful article you might find. So in our case, this woman had migraines that were well controlled prior to her COVID, but when her COVID came along, they become incredibly difficult for her to get symptom relief. So 2 years after long COVID, she didn't have a traditional improvement with the therapies that were available, and she still experiences them, but they have settled over time. And her neurologist gave her gold standard care, and the headaches were often made worsening with brain fog and neuropsychiatric conditions. So this is a good example of migraines in long COVID. Lightheaded with postural change. I really always want you to think about postural orthostatic tachycardia syndrome. In long COVID, the prevalence reported in the articles that I've reviewed are up to 30%. There are differences between long COVID POTS and non-COVID POTS, and I have slides for reference for you, and Avabradine has some evidence for efficacy. Again, just a repeat of what I've already said, this is a borrowed slide, so you can have this for reference. Again, this is another reference slide that I have for you, not so much that I want to go over it, but just explaining the hemodynamic differences between long COVID POTS and non-COVID POTS. So management of long COVID POTS, at the moment, it's still, from my understanding, the same as we manage non-COVID POTS. So up to 2 teaspoons of salt a day, 3 liters of water, compression garments to the waist, and exercise. Usually I like to involve a physiotherapist that's familiar with POTS or dysautonomia, so that the appropriate exercises are offered. So I want to just highlight compression garments. Again, this is a borrowed slide, and you can see the difference in heart rate. And the heart rate difference is pretty profound. So just more evidence that those compression garments make a difference. One of the problems with compression garments, from many that you'll hear, is the prescription ones are hot, tight, itchy, and very difficult in the summer. and compression ranges can be up to 20 to 40 millimeters of mercury. So we sometimes have to reach a compromise with our patients. And so commercial compression stockings that can help are high-end athletic wear, triathlon tights. You may get 15 to 18 millimeters of mercury. So there's not as much compression, but they're more comfortable and more fashionable, and you'll likely get more buy-in from your patient for wearing. And just this comes from the CCS position paper on POTS. And this is how, after you've done the saltwater compression, how I use evidence for helping decisions with regards to making treatment decisions for POTS. So I mentioned fatigue because it's the most common symptom you're going to hear. Please note you need to ask for the triggers of the fatigue. They can be physical, cognitive, which is often what many miss, and other triggers. So this is a relatively recent article on long COVID fatigue. So you have to ask about post-exertional malaise. Again, what is the definition? Very important to understand. Marked rapid physical and or cognitive fatigability in response to exertion, low threshold of physical and mental fatigability, reduction in pre-illness activity levels, post-exertional symptom exacerbation, exhaustion, and a prolonged recovery period. Usually it's 24 hours is what's in part of the definition in the CCS guidelines here. So when you're talking about PEM with an individual, you want to find what their triggers are: physical, cognitive, emotional, family, stress. It can occur after a triggering event, and quantifying length of PEM is important. And I've given you a bit of a reference for this here. So how common is ME/CFS in long COVID? Well, it depends on where you're looking, actually. And this is a pooled prevalence of PEM. Part of the definition of ME/CFS was 25% among community dwelling adults. And here are the differences in incident rates and hazard ratio. So just some information for you on the commonness of ME/CFS. So evidence-based decision-making is always best. Unfortunately, there's no Canadian guidelines for the management of ME/CFS. So I often go to the American literature, and this is from Bateman Horn, and it's a fairly good resource for you. I want to direct everyone to the Canadian guidelines for post-COVID condition or long COVID, because I think this is a very well put together guideline that gives you a good starting place for both investigation and management of your patient. So, with this case, again, shared decision-making, interdisciplinary team. So what symptoms we can make a difference in are things like treatment of POTS, helping with headaches. This particular person did not want to go the medication route because of a lot of side effects in the past, and that's important to recognize and acknowledge and respect. So unfortunately, she had her disability taken away from her. And I did have to write an appeal letter. Just a plug that we do have to think of doing advocacy work for our patient population, and you may need to help with letters for long-term disability. So now she's at a very different stage. She is accepting where she's at right now. She's using various different self-management strategies. She's pacing a lot, meditating, scheduled rest breaks, supplements. She has a positive outlook. She's grieved her lost self, is still grieving her lost self, but is coming to a different level of acceptance with where she is right now. So I just want you to know that COVID is not gone. And this is from wastewater management that I found. So you can really notice that it is still present. And this is weekly and updated, so please have a look. So some of the strategies to prevent long COVID and post-COVID condition are really important. Masking is important. Ventilation. So there's many types of ways of doing ventilation. The HEPA filter to the do-it-yourself models, or if anything, a cross breeze in your office. CO2 monitoring can be helpful as well, because that's the quality of the expired air around you, and it should be below the 600 parts per million. And remember vaccination as per public health recommendations. So for acute COVID with long COVID, you really don't want your individual with long COVID to have another infection because they can get a setback. So always look at the CAN PCC guidelines. There's information for metformin. There's information for another combination antiviral that I'll encourage you to have a look at. So just in closing, I really would like you to, when you're seeing individuals with long COVID, just be open to adding them into your practice, and always approach with compassion and curiosity, and be aware that many health experiences they have experienced before you may have not been so easy. So with that, I want to bring my talk to a close, and I have one more slide of references for POTS for you that you can have a look at. So thank you so much.